Okay, welcome to part 7 of Pharmacology class. I think we'll finish off as fast as we can, right? So we'll go to the next page. Okay, I think previously we stopped at parasympathetic. We will discuss, what is parasympathetic. We will discuss what is the outflow, what is the nervous outflow of parasympathetic. It's craniosacral outflow. And what is the craniosacral, which cranial nerves? That is 3, 7, 9, 10. And what is the sacral component? It is S2, S3, S4. So that is the craniosacral outflow, which is parasympathetic. You have two types of receptors, muscarinic and nicotinic. And what is the neurotransmitter? It is acetylcholine. It's acetylcholine is the neurotransmitter in parasympathetic system. What is the rate limiting step? This is very important. It's an MCQ. What is the rate limiting step? It is choline reuptake. Choline reuptake is the rate limiting step in parasympathetic. Choline reuptake is the rate limiting step in parasympathetic. And we will discuss about some of the drug components, that is aminoglycoside. They block the presynaptic voltage gated calcium channels and decrease the release of acetylcholine. That is one thing which relates to parasympathetic. And one more very important component regarding parasympathetic is the botulinum toxin. Botulinum toxin. How does this botulinum toxin acts on parasympathetic system? That is, it blocks release of acetylcholine. This is very important. After I think in the next classes we will discuss, right? See, if this is a synapse, we have sodium gated channel, ion gated channel, we have calcium gated channel, then we have vesicles here. What are these vesicles? These are acetylcholine vesicles. And we have postsynaptic membrane, and we also have here one more ion gated channel, right? So we will discuss in the next classes what are the things which block the vesicles, which block the calcium gated channel, which block the sodium gated channel. All these we will discuss, right? But for now we will go on with the next topics, that is when we discuss about sympathetic. When we discuss about sympathetic, the nervous outflow is dorsolumbar. Dorsolumbar. It is the outflow tract of sympathetic system. Dorsolumbar, from which nerve roots? It will be from T1 to L2 or L3. T1 to L2 or L3. That is the sympathetic outflow. What is sympathetic outflow? It's dorsolumbar outflow. Now, what are the receptors in sympathetic? It is alpha 1, alpha 2, alpha 1, alpha 2, beta 1, beta 2 and beta 3. Beta 1, beta 2 and beta 3. What is the neurotransmitter in sympathetic system? It is norepinephrine. Very important. What is the neurotransmitter in sympathetic system? It is norepinephrine. Sorry. It is norepinephrine. Very important. Remember this one. Now, if you ask me what is the MCQ here, you have a exception. You have a exception in sympathetic system where norepinephrine is not the neurotransmitter. Where it is the exception? In renal blood vessels. In renal blood vessels, it is not the norepinephrine that is the neurotransmitter, it is dopamine. Dopamine is the neurotransmitter in renal blood vessels. So dopamine is the neurotransmitter in renal blood vessels. It is a potential MCQ regarding sympathetic nervous system. Sympathetic nervous system where norepinephrine is not the neurotransmitter. Norepinephrine is generally the neurotransmitter in sympathetic nervous system, but exception is renal blood vessel where dopamine is the neurotransmitter. Remember, it is an MCQ. Okay, and there is one more exception, that is adrenal glands and sweat glands. Adrenal glands and sweat glands where the neurotransmitter is acetylcholine. This is also potential MCQ. This is also a potential MCQ. So there are completely three things where even though they belong to sympathetic system, but still norepinephrine is not the neurotransmitter there. In renal blood vessels, the neurotransmitter is dopamine, and in adrenal and sweat glands, the neurotransmitter is acetylcholine. But actually, acetylcholine is the neurotransmitter of which system? Parasympathetic. But in sympathetic system also, we have acetylcholine as a neurotransmitter in adrenal gland and sweat glands. That's the exception, and that's an MCQ. Now, what's the rate limiting step in sympathetic system? It is tyrosine to dopa. It is tyrosine to dopa. Using which enzyme? Tyrosine hydroxylase. Tyrosine hydroxylase enzyme. Okay. So, what is the rate limiting step in sympathetic? That is tyrosine to dopa. Now, mention some drugs in sympathetic system. If you ask me, for example, with their mechanisms regarding the sympathetic system, I will tell you. The first one is metyrosine. What does this metyrosine do? This metyrosine, it blocks tyrosine hydroxylase. Now, can you tell me what happens if tyrosine hydroxylase is blocked? If tyrosine hydroxylase is blocked, tyrosine will not be converted to dopamine. If tyrosine is not converted to dopamine, then there will not be any neurotransmission, or there will not be production of catecholamines. Catecholamines are the neurotransmitters, hormones which are neurotransmitters. So, there will not be production of the neurotransmitters. So, this metyrosine is used in the treatment of pheochromocytoma, which is a tumor of adrenal gland due to what is the feature that we see in pheochromocytoma? There is an excess release of catecholamines. And one more thing is, this metyrosine is a blocker. This metyrosine is a blocker of VMAT2. VMAT2. What is meant by VMAT2? It's vesicle monoamine transporter. It's vesicle monoamine transmitter. Okay. Then there is one more drug called tetrabenazine. So, these are the drugs which act depending on the which act regarding the principles of sympathetic system. Okay. What does this tetrabenazine do? This tetrabenazine is a drug of choice in Huntington's chorea. And one more thing is, it's also a drug of choice in Tourette syndrome. Okay. Now, we will go into the briefer concepts. Now, from this, you listen carefully. This is a little bit confusing, but still, if you listen carefully, everything will be all right. Okay. Now, we will discuss everything parallelly. Okay, in a parallel manner. Parasympathetic. Okay, or it's also called parasympathomimetic. Okay. Next one is parasympatholytic. Next one is sympathomimetic. And last one is sympatholytic, or also called anti-adrenergic or adrenergic blockers. Sympathomimetic, sympatholytic. Now, when we come to parasympathomimetic or parasympathetic, right? So, we will check regarding different systems, different body systems, that means CNS, pupil, how these systems they work, or how these systems function, or how these systems produce their actions regarding different systems. For example, we will start with CNS. Okay, we will start with CNS. I think okay, no issues. We will start with CNS. First we will start with CNS. Okay, regarding CNS, if you ask me, parasympathetic system increases cognition. Parasympatholytic are also called anticholinergics. They decrease cognition. Sympathomimetic does not have that much action or that much workout regarding this one. But if you ask me, sympatholytics, they produce side effects. What are the side effects? We will discuss later. Now, increase cognition. Now, one of the drug of parasympathomimetic or parasympathetic, that is donepezil, which increases cognition, which this principle is used as drug of choice for Alzheimer's. Donepezil is the drug of choice because it increases cognition. Now, parasympatholytic or anticholinergic, they decreases cognition. So, where do we use this drugs? In that is scopolamine. Scopolamine is a parasympatholytic which is used as truth serum, because what a truth serum does is it decreases the cognition of that so called individual by which he will speak the truth. If some police is investigating a criminal, obviously he does all sort of tactics to escape from the justice. But if that guy is given with the truth serum, that is scopolamine drug, which is a parasympatholytic drug, it is used as truth serum. What it does is it decreases the cognition of that individual, which is used in narcoanalysis. Now, sympathomimetic we already discussed, there is nothing much about me, but sympatholytic drugs cause side effects regarding the CNS system, because sympatholytic drugs, those are beta blockers, they cause some side effects like they cross the blood brain barrier because they are lipid soluble. So, they crosses the blood brain barrier and they cause depression. Insomnia and nightmares. So, these are the actions on CNS of different systems: parasympathomimetic, parasympatholytic, then sympathomimetic and sympatholytic. These are the actions done by different drugs of different systems on the CNS. Now, when coming to pupil, how these drugs act on pupil? Now, parasympathomimetic or parasympathomimetic or parasympathetic drugs cause active miosis, means cholinergic drugs cause active miosis. Parasympatholytics cause passive mydriasis. So, first we will talk about parasympathomimetic, that is active meiosis. They cause active meiosis by M3 receptor stimulation. And drugs that are causing active meiosis, example are pilocarpine, and one more drug is physostigmine. Now, passive mydriasis is seen in parasympatholytic drugs action. Parasympatholytic drugs cause passive mydriasis due to M3 blockade, M3 receptor blockade. Now, they also cause cycloplegia, blocks M3. Now, what are the drugs that cause parasympatholytic drugs that cause this is tropicamide. Remember this, okay? Tropicamide, remember this. Now, some examples, those are atropine and homatropine and cyclopentolate. pentolate. So these are the parasympatholytic drugs which cause passive mydriasis. This passive mydriasis is due to M3 blockade. Remember doctors, it is due to M3 blockade. Passive mydriasis is due to M3 blockade. Now sympathomimetics, they cause active mydriasis. Sympathomimetics cause active mydriasis. And drugs are example phenylephrine and ephedrine. Okay. Now sympatholytic drugs cause passive meiosis. Sympatholytic drugs cause passive meiosis. Example, can anyone tell us example? Phenoxybenzaimine and prazosin. So these are the examples of sympatholytics which cause passive meiosis. So in a broad way, we will just discuss parasympathomimetics or cholinergics cause active meiosis, anticholinergics, that is parasympatholytics, cause passive mydriasis, sympathomimetics cause active mydriasis, sympatholytics cause passive meiosis. Now some of the students may get a question, or they will get a doubt like, sir, what is meant by passive meiosis, passive mydriasis, active mydriasis, right? I will just explain it in short. After that you can discuss somewhere, right? I will just explain it in short. So sorry, my drawing is it's not good, but still I will make some arrangements for this. We'll take a circle. Okay, we'll take a circle. Right now, if you take a circle, so this is I'll just wait, I'll just increase it, I'll just increase, right? Now you just take a circle, and this is normal pupil, this is mydriasis, this is meiosis, right? Should be pinpoint pupil, it's meiosis. Okay, now this one should be something normal, so we'll keep it like this. This is mydriasis. Okay, so what happens is, there are two types of fibers. Listen carefully, doctors, listen carefully. One is striated, these are circular fibers, and these are radial fibers. Okay, these are circular fibers, these are radial fibers. Okay, just listen carefully. Okay, so what happens is, in case of a sympathomimetics, that is adrenergic drugs, what happens is, adrenergic drugs, this one, that is the radial fibers which has beta receptors, they get activated, so they get constricted, causing active mydriasis, right? Now in case of parasympathomimetic, that is cholinergic drugs, M3 receptors get activated. The M3 receptors present on this circular fibers, M3 receptors, they get activated, producing active meiosis. So sympathomimetic drugs produce active meiosis. How? Active meiosis due to M3 activation. M3 activation causes constriction of circular muscle fibers. Now sympathomimetic sympathomimetic, that is adrenergic drugs, they cause active mydriasis. How? Can anyone tell? They cause active mydriasis by M3 beta receptor activation. So beta receptors get activated, leading to constriction of radial fibers. See, I will just draw it with another color. These are radial fibers. Now these are circular fibers. Right? So sympathomimetics causes activation of beta receptors, leading to constriction of this radial fibers, leading to produce active mydriasis. Now if you ask me parasympatholytic, that is anticholinergic, they cause passive mydriasis. Why they cause passive mydriasis? Because they block the M3 receptor. So if you block the M3 receptor, the M3 receptors will be blocked and the circular muscle fibers will be relaxed. They will not constrict, they will be relaxed, leading to causes of mydriasis. And if you ask me sympatholytics, what happens is they cause passive meiosis. But how? These sympatholytics, they block the beta receptors. Why? Because sympatholytics are antiadrenergics. Antiadrenergics are something which block beta receptors or alpha receptors, but the sympatholytics block the beta receptors, causing to passive meiosis. Why? Because beta receptors, if activated, cause what? Constriction of radial fibers, leading to mydriasis. But if these beta receptors are blocked, the radial fibers will be relaxed and it may lead to passive meiosis. Meiosis is passive meiosis. So this difference, please, each and every doctor, please understand. Okay, I think we discussed enough about it. We'll go to the next thing. So what is the next thing? Oropharynx. Regarding oropharynx, what different systems will show what sort of actions? If you take parasympathomimetic, these drugs, wait, parasympatholytic, next sympatholytic. Okay, now regarding eye, sorry, I forgot about eye. Regarding eye, what these different systems will do? Parasympathomimetics, these drugs are used in closed angle glaucoma. Remember this, parasympathomimetics, that is cholinergics, they are used in closed angle glaucoma. If you ask me, it is pilocarpine which is the drug of choice. Now if you ask me parasympatholytic, they are used in ocular fundus examination, and they are also used for prevention of synechiae. They are also used as adjuvant in corneal, which is due to corneal ulcer, which is due to fungal origin, right? It is also used as adjuvant. These parasympatholytic drugs are used as adjuvants in corneal fungal corneal ulcer. They also decrease pain in iridocyclitis. And they are also used in refractive error test. You got this? Now sympathomimetics, what happens is they don't have much utilities in case of they don't have much utilities in case of orbital system, and sympatholytics also they don't have much actions in case of orbital or eye ophthalmological conditions. Now coming to next is oropharynx. In case of oropharynx, how these drugs will be used? In case of oropharynx, how these drugs will be used? Parasympathomimetic, that is cholinergic drugs, they increase secretions. So where it can be used, in which conditions secretions needs to be increased? Used in xerostomia. Xerostomia means dryness of mouth, and the drug used is pilocarpine. Xerostomia means dryness of mouth, and the drug used is pilocarpine, and also we use one more drug, that is cevimeline. Okay. Now parasympatholytic, that is anticholinergics, they decrease secretions, they decrease the secretions. Now in which conditions they are used for this purpose? In as pre-anesthetic drug, Now what is an example for it is glycopyrrolate, which is a quaternary amine, and it does not cross the blood brain barrier. It is more, it is superior than atropine in this use. It is superior than atropine. Remember why? Because glycopyrrolate is a quaternary amine and it does not cross the blood brain barrier. Just remember this. Sympathomimetics you don't have much uses, and sympatholytics you don't have much uses. Okay. Now going to the next thing, which is in case of pulmonary orientation, pulmonary system, how these drugs are used, right? In case of pulmonary system, how these drugs are used? Parasympathomimetic, parasympatholytic, sympathomimetic, and sympatholytic, right? Sympatholytic. Now parasympathomimetics are contraindicated in asthma. Why? Because they cause bronchoconstriction. They cause constriction, bronchoconstriction, as well as they increase the secretions. Right? Cholinergic drugs, what they do? They increase the secretions, so they are contraindicated. But parasympatholytic are very much beneficial in case of asthma. In case of inhalational, which drugs are used? They are used as inhalational drugs, that is PMDI, metered-dose inhaler, and there are some different classes of drugs regarding their duration of action. For example, long action muscarinic agents. Just 1 minute. Long acting muscarinic agents, right? So what are this example? It is ipratropium bromide, and just 1 minute. Sorry, it's not ipratropium bromide, it's tiotropium bromide. And this tiotropium bromide is the drug of choice in COPD. Remember this, drug of choice in COPD. Now there are some other drugs which are long acting muscarinic agents like umeclidinium and renifenacin. Okay. Now if you ask me intermediate acting muscarinic agents, it is eclidinium. It's eclidinum. Now if you ask me short acting muscarinic agents, it is ipratropium bromide. Very important drug. Mechanism of action is also very important. Now what is the most common side effect of this parasympatholytic drugs? It is dryness of mouth. dryness of mouth. Why? Because they are anti-secretory drugs, they decrease the secretions, so obviously they cause dryness of mouth. Okay. Now if you ask me, sympathomimetics, they cause dilation, they cause bronchodilation. Parasympatholytics cause bronchodilation, but parasympathomimetics cause bronchoconstriction. Remember this. That's why they are contraindicated in asthma, because they increase the secretions as well as they cause bronchoconstrictions. So they are contraindicated in asthma and COPD also. Okay. So dilation, sympathomimetics cause bronchodilation. Now example, SABA, short acting beta agonists, that is salbutamol, short acting beta agonists, terbutaline, pirbuterol. Remember, pirbuterol is a short acting beta agonist, SABA. These are used for COPD or bronchial asthma. Okay. Now there is LABA, long acting beta agonist, that is olodaterol. This is very important MCQ. olodaterol. Okay. Olodaterol. Next, vilanterol. Formoterol. Long acting beta agonist is formoterol. And salmeterol. This is long acting beta agonists, formoterol and salmeterol. Now if you ask me, very long acting beta agonists, that is olodaterol, then vilanterol, and there is one more drug, that is carmoterol. Okay. Carmoterol. Yes, you got my point. Just one minute. Okay. Now if you come to sympatholytics, that is adrenergic blockers, what they do is, beta blockers are contraindicated in asthma. Very important in clinical practice also. Never suggest a beta blocker to a asthma patient, and COPD also. But one exception is there, but it's not that much important. Cardioselective beta blockers can be used, but with very much caution only you can use cardioselective beta blockers. Rest of that beta blockers are highly contraindicated in asthma as well as COPD. Okay. Now what happens, or what they do in case of cardiovascular system? How do they act? How these drugs act in case of cardiovascular system? Parasympathomimetics, parasympatholytics, sympathomimetics and sympatholytics, right? So what in case of CNS, how do they act on heart? That is very much important, right? We'll just make it fast. Okay, what they do is they decrease the heart rate, and they decrease the AV conduction also, atrioventricular conduction. They decrease the AV conduction also. And one more important thing is edrophonium, which is anticholinesterase inhibitor. Edrophonium is used in PSVT or SVT, supraventricular tachycardia, or paroxysmal supraventricular tachycardia. Okay. Now parasympatholytic drugs or anticholinergic drugs, they increase the heart rate and AV conduction also. So what is the drug? One of the drug is atropine. Atropine is given to increase the heart rate and atrioventricular conduction. It is used in bradycardia. They are generally used in bradycardia, and also they are the drug of choice. They are the drug of choice in bradycardia, which is more than 0.5 mg. They become the drug of choice. And AV block digoxin toxicity. They are also used in case of digoxin toxicity, which leads to AV block. These drugs are also used in AV block, which is caused due to digoxin toxicity. Digoxin toxicity. In digoxin toxicity, we can give treatment with parasympatholytics, okay, because they increase the AV conduction as well as the heart rate. Then coming to sympathomimetics, they increase the heart rate and AV conduction. They increase the heart rate and AV conduction, and also the contractions also. They increase the contractions also of heart. Now, epinephrine, which is a primary sympathomimetics. Epinephrine is primary sympathomimetics. Epinephrine is used in bradycardia in children, and it's also used in cardiac arrest. These are very important statements, you just listen. Now, sympatholytics, they decrease heart rate and AV conduction. They decrease heart rate as well as AV conduction, and they are the drug of choice for atrial fibrillation, atrial flutter, and HOCM, hyperobstructive cardiomyopathy, and aortic dissection. For all these four things, they are drug of choice. Remember, sympatholytics are the drug of choice for atrial fibrillation, atrial flutter, HOCM, hyperobstructive cardiomyopathy, and aortic dissection. Now, coming to the next thing, what is their mechanism, or what is their action on the blood vessels? What is their action on the blood vessels? Right? If you take parasympathomimetic, how do they act on the blood vessels? What they do is they cause, just 1 minute, first we will discuss about sympathomimetic. Leave about parasympathomimetic, we don't want much about it. We will discuss about sympathomimetic. This is very important. They cause sympathomimetic drugs cause vasoconstriction. And one more important thing is they are used in spinal anesthesia induced hypotension. They are used in spinal anesthesia induced hypotension. If some person is given with spinal anesthesia and suddenly he land up in hypotensive state, then obviously you can give sympathomimetic drugs. For example, if you want to normalize or if you want to increase the heart rate, one of the best drug is phenylephrine. You can give phenylephrine. If for postural hypotension, you can give midodrine. And it is the drug of choice for postural hypotension. If you want to decrease the heart, for a patient in which the heart rate gets decreased, you can give ephedrine. If the patient's heart rate is decreasing, you can give ephedrine. But for postural hypotension, the drug of choice is midodrine. Remember this, it's an MCQ. Cardiogenic shock or septic shock, always the drug of choice is very, very important. Cardiogenic shock or septic shock or neurogenic shock also, the drug of choice is IV norepinephrine. Very, very important. IV norepinephrine, very important. Cardiogenic shock or septic shock or neurogenic shock also, the drug of choice is norepinephrine. Right? Got my point? Next one. For anaphylactic shock, you give what? Epinephrine. For anaphylactic shock, we give epinephrine, and it is the drug of choice. It is the drug of choice. In case of decreased, I think we don't want to discuss much further. We will go for sympatholytics. Or antiadrenergics. Sympatholytics or antiadrenergics. When I come to sympatholytics, what they cause? They cause vasodilation in blood vessels. Now, what are their uses? As preoperative, they can be used in preoperative hypertension that is caused in pheochromocytoma. In case of pheochromocytoma, for example, a patient with pheochromocytoma is undergoing for surgery. So, preoperatively you can give sympatholytics. Which drug you can give? That is the question. That is the MCQ question. Which drug you can give is phenoxybenzaimine. Phenoxybenzaimine is the drug of choice for patient with pheochromocytoma for preoperative hypertension in pheochromocytoma. Phenoxybenzaimine is the drug of choice for preoperative hypertension in pheochromocytoma. Next, one more drug is cheese reaction. See, phentolamine. You remember this drug? Phentolamine is the drug of choice. In cheese reaction, clonidine withdrawal hypertension, and also intraoperative hypertension in pheochromocytoma. This is important. Intraoperative hypertension. Intraoperative hypertension in pheochromocytoma. See, don't confuse with these drugs. Phenoxybenzaimine is the drug of choice in preoperative hypertension in pheochromocytoma, whereas phentolamine is the drug of choice in intraoperative hypertension in pheochromocytoma. Don't confuse both of those things. Okay. Now we have one more drug, that is prazosin, which is the drug of choice in scorpion bite induced hypertension or pulmonary edema. Prazosin is the drug of choice in scorpion bite induced hypertension or pulmonary edema. Then we have if the patient is a benign prostatic hypertrophy patient with hypertension, then you can give terazosin and terazosin and doxazosin. What are these two drugs? Terazosin and doxazosin are alpha blockers. What are the alpha blockers? Prazosin, terazosin, doxazosin, tamsulosin. So these are alpha blockers, right? So if the patient is a benign prostatic hypertrophy with hypertension, you can give terazosin or doxazosin. Now if the patient is a young individual but he has hypertension, then you can give beta blockers. So these are the drugs, these are the uses, these are the drug of choices that you should remember for sure. Now I just want to tell you one thing. Long acting drugs, that is salmeterol, formoterol, right? These drugs can be used as reliever in intermittent asthma. What is meant by intermittent asthma? They are used as relievers in intermittent asthma. You should know the definition of intermittent asthma because you will get a question like this. So less than 2 attacks per week. If the patient gets less than 2 attacks of asthma per week, then it is determined as intermittent asthma, in which you can use long acting beta agonists, that is salmeterol, formoterol, those things, but they can be used as relievers. But if you want to use drugs for persistent asthma, what are the drug protocol? What is the drug protocol that you will use? That is formoterol or salbutamol, salbutamol plus one inhaled corticosteroid is used for persistent asthma. Very long acting beta agonists, they are not used. What are these very long acting beta agonists? Olodaterol, vilanterol, carmoterol. They are not used in asthma, but they are only used in COPD. Very long acting beta agonists, they are only used in COPD. This is also one important point. Okay, so what are the side effects of beta agonists? This is also very much important. You may get a potential MCQ. What are the side effects of beta agonists? What are the side effects of beta agonists? Palpitations. This is the most important side effects. Palpitations, tremors. Why these occur? Because they occur due to hyperglycemia. And hypokalemia. Okay, so these are some important points that you should remember. Now see, we discussed sympathetic and sympathomimetic and sympatholytic actions on blood vessels, but I forgot to tell you one important note. Epinephrine acts on beta 2 receptor. Remember this statement is very important. Epinephrine acts on beta 2 receptor. Okay, now what is the dose of epinephrine? That is important, very important. It's 0.5 mg intramuscular at 1:1000 dilution, right? It is simply 0.5 mg intramuscular at 1:1000 dilution. This statement is very important because you will get a question for sure. They will ask you the dilution 1:1000. Now what is the side effect of clonidine? We will discuss multiple times. It is withdrawal hypertension. Withdrawal hypertension is the side effect of clonidine. Now if you ask me treatment of pheochromocytoma, it is simply alpha blockade followed by beta blockade. Pheochromocytoma, that is alpha blockade followed by beta blockade. Always remember this statement. In pheochromocytoma, the treatment should be alpha blockade followed by beta blockade. Okay, the sequence should go like this. First of all, you should block this production of catecholamines. Okay, alpha blockade followed by beta blockade. After the decreasing of catecholamines production only, you should go for the decreasing of blood pressures, right? Now what about the action on GIT, right? You take parasympathomimetic. Guys, it might look a bit clumsy, but still you should learn. Parasympatholytic. These are very important questions, topics, very important. Regarding GIT, what happens to acidic secretion and bowel contractions? What happens to acidic secretions and bowel contractions? They simply increase in parasympathomimetic drugs action, and parasympatholytic drugs cause decrease in gastric secretions. As simple as like. Now what is the use that you can obtain from these mechanisms? In gastroparesis, you can give parasympathomimetic drugs, and also post-op ileus also you can use parasympathomimetic drugs. What are those drugs that we can use? Bethanicol, neostigmine. They can be used for gastroparesis and post-op ileus. Now if you ask me parasympatholytic, They are used as antispasmodics. They are used as antispasmodics because they decrease the contractions. What is meant by spasm? It's a prolonged contracted state of the muscle. Prolonged contracted state of the muscles that leads to spasmic contraction, which leads to pain. So we give antispasmodics, that is parasympatholytic drugs which decrease the contractions. What are the examples? The drugs are glycopyrrolate. And dicyclomine, then followed by scopolamine, then you give these drugs for peptic ulcer also, but rarely you give, you use these drugs for peptic ulcer. What are the examples? That is pyrangiapine and talangapine. These. Now there is one important thing in this parasympatholytic. What is the drug of choice for motion sickness? You got multiple times this question, multiple times. I can't say how many times you got this question, but multiple times. Nearly 3 question papers, 3 years question papers I will see in this question. Drug of choice for motion sickness, it is scopolamine. Remember, it is scopolamine transdermal patch, which is kept 4 hours before the journey, which is kept at least 4 hours to 5 hours before the travel or journey. Why it is 4 hours to 5 hours before? Because in order to achieve steady state concentration, of the drug, you should keep the transdermal patch 4 to 5 hours before the travel or journey. So drug of choice for motion sickness is scopolamine transdermal patch. Okay. Now we will be coming to your bladder, that is urinary system. Renal system we'll call it. Why urinary? What is these actions on renal system? Don't get bored, my friends. See, okay, fine, we'll just throw some joke. Okay, see, MBBS is like you go on your, leave out MBBS, you go for PG preparation. You have to keep all the deviations aside. It looks a bit something like vague, it looks boring, it looks everything, it looks like boring, it looks like very torture, it looks like very haze. You have girls beside you, you are watching girls, and for girls you watch so many boys going beside you. They are having so much of money, these boys are having so much of money. The girls attract to boys and boys attract to girls. All these attractions, social media, everything. You can't post pics in Instagram, you can't post pics in FB, you can't hang out with friends, you can't have fun, you can't have parties, you can't have nothing, booze, anything. But still, at least you can do some hard work. This is all bullshit. This is temporary. Just like, see, one click, it goes, it vanishes. So the permanent thing is hard work. You do, you revise the topics which I explain here. You repeat them. You do the MCQ. You go for the exam with confidence, you write the exam perfectly, and finally you come with colors, securing a good PG seat. If you did not obtain the PG seat also, no problem. Restart the cycle once again. Restart the cycle. That's as simple as like it. Don't make it complicated. No more multiple resources. Don't go here and there. Don't wander here and there, right? You stick to only one resource, right? You watch my videos, fine, or you watch other videos, fine, you stick to others notes, fine, it's everything is fine, but only thing is you follow this cycle. You just follow this cycle, hard work, revise the topics, repeat the concepts, do lot of MCQs, go to the examination, you get the PG seat. Even if you get a good dream oriented PG seat, still repeat the cycle. One day you will become a successful doctor. Trust me, right? As always I said, even in the previous classes I said, Sachin Tendulkar has passion. Sachin Tendulkar became a good cricketer because he have passion. Michael Jackson became a good dancer because he has passion. And Amitabh Bachchan became a good actor because he has passion. But Johnny Sins does not have passion. Johnny Sins have something called dedication. You should have the dedication. Yes, you also should have the passion, but you should have the dedication. Remember this. Always be Johnny Sins, okay? But don't do the Johnny Sins profession. I am not telling about the profession, but I am telling about the dedication. Remember. So back to the concept. We will discuss about the renal things. We will discuss about the action of these systems on renal system, right? Just stick to me, we'll make it as fast as possible, okay? Now parasympathomimetic and parasympatholytic, sympathomimetic. What is the actions that they exhibit in case of renal system? They cause M3 agonistic action. They are M3 agonists, parasympathomimetic, which leads to detrusor contraction. They are M3 blockade, as we already seen previously. So M3 blockade, so detrusor relaxation. Now these also called detrusor relaxation by M3 blockade. Okay. Now, in which conditions we use this? Bladder atony. If there is absence of tone in the bladder atony, urine retention, so we use parasympathomimetics in bladder atony and urine retention. What are the examples? This is very important: bethanicol and neostigmine. Now, in which conditions we use parasympatholytics? Overactive bladder or urge incontinence. Example, you just remember this mnemonic friend. Friend, dost. Friend means dost. Festerophenadine, F for festerophenadine. Listen carefully. F for festerophenadine, darifenacin, oxybutynin, solifenacin, tolterodine, trosmium. This darifenacin is very important drug. Remember this. Darifenacin is very important drug. Darifenacin, oxybutynin, next solifenacin, tolterodine, trospium. And F for festerodine. F for festerodine. Very, very important. Just remember these points. Now, if you come to sympathomimetics, they cause detrusor relaxation by M3 blockade. Where do you same like overactive bladder, same as like parasympatholytic, overactive bladder and urge incontinence, same like parasympatholytic, urge incontinence. Now, what are the drugs? mirabegron or vibagron. These two are beta 3 agonists. In case of stress incontinence also we use, this is very important. Stress incontinence, which drug we use? Duloxetine, which is a SNRI, selective norepinephrine reuptake inhibitors. They just simply increase norepinephrine by stimulating alpha 1. They increase norepinephrine by stimulating alpha 1. Okay, so that is the regarding renal system. Now if you come to muscular system, how these drugs act. Now if you come to muscular system, how these things act. Parasympathomimetic, parasympatholytic, sympathomimetic and sympatholytic, right? These cause contraction. Parasympatholytics cause relaxation, sympathomimetics cause contraction, sympatholytics cause relaxation. Now listen carefully guys, this is very important. Parasympathomimetics are used in myasthenia gravis. Okay, what is the drug we use? It is pyridostigmine is the drug of choice. Pyridostigmine is the drug of choice in myasthenia gravis. Now if you ask me, parasympathomimetic drugs are also used to differentiate between cholinergic crisis and myasthenia gravis. By which test this diagnosis, the differentiation between the cholinergic crisis and myasthenia gravis, this is done by the test called Tensilon test, and the drug used here is edrophonium. Edrophonium is the drug used in Tensilon test. Tensilon test, for what purpose we do the Tensilon test? It is used for the differentiation of cholinergic crisis from myasthenia gravis, and the drug used is edrophonium. And these drugs are also used in cobra bite reversal and NDMR reversal, and the drug used is neostigmine. Cobra bite reversal and NDMR reversal, and the drug used is neostigmine. What is meant by NDMR reversal? Non-depolarized muscle relaxant reversal we use. What is the drug we use? It is neostigmine. Okay. Now in case of parasympatholytic, they are used for relaxation of the muscles. They cause relaxation of muscles. So these are used as NDMR, non-depolarizing muscle relaxants, in case of during anesthesia. Okay. Now sympathomimetics causes contraction of muscles, so they due to beta 2 agonists. Example, clenbuterol. They are used. This clenbuterol is used as performance enhancers by athletes. But they are banned in Olympics, and side effects is tremors. Now if you come to sympatholytics, they cause relaxation. They decrease exercise tolerance, but they are not prescribed in athletes. Okay. Now I just want to write one thing here. When using neostigmine or hydrophonium, remember, when using neostigmine or hydrophonium for any treatment, when using neostigmine or hydrophonium, you always combine atropine or simply add atropine. Okay, now I think we finished up to there. Just 1 minute, I'll just check. Still actually we have good amount of thing. Fine, we will stop up to this point. Okay, in the next class we will discuss rest of the things, right? Okay, fine, then we will discuss the side effects also. Wait, we'll discuss the side effects also. It will not take much time. Side effects of ANS drugs. Now what are the side effects of ANS drugs, right? If you take parasympathomimetics, that is anticholinesterase inhibitors, parasympathomimetics cause OP poisoning, organophosphorus poisoning, that is cholinergic poisoning. What are the clinical features? Can anyone tell? Salivation, different salivation, meiosis, sweating, involuntary muscle, involuntary urination, then involuntary defecation, then bradycardia. This is the most important clinical feature of OP poisoning, bradycardia. Most important clinical feature of OP poisoning. Now, what is the treatment? Right? Atropine is the drug of choice. Most of the doctors confuse whether it is atropine or pralidoxime. Doctors, remember, it's the atropine, the drug of choice. If they ask you drug of choice, it's atropine. But if they ask you most specific drug for OP poisoning, then only you should tick the pralidoxime option. If they ask drug of choice, it's absolutely atropine. Remember, don't make any mistake. If they ask you most specific drug, you just say pralidoxime. Okay, it's the most specific drug of OP poisoning. Now what is the now atropine is given, but here one small thing is there. Atropine reverses each and every parasympathomimetic or cholinergic effect, but it cannot reverse one cholinergic effect. What is that one cholinergic effect? Muscle weakness. It cannot reverse the muscle weakness in OP poisoning. This is very important MCQ. It cannot reverse the muscle weakness in OP poisoning. Okay. Now, most specific sign. Now, if you give the atropine, obviously that's defined as atropinization. Now, after you give the atropine, it's defined as atropinization, giving atropine to the. What is the most specific sign? What is the most specific sign of atropinization during the treatment of OP poisoning? Decreased respiratory secretions. Remember this, very, very important. Decreased respiratory secretions. Okay, that is all about OP poisoning. Now, if you come to atropine poisoning, that is, atropine poisoning is due to anticholinergic poisoning, or it's also called parasympatholytic drug poisoning. It is due to atropine or Datura belladonna poisoning. Datura belladonna. What are the clinical features? Same as like midriasis, all the actions of anticholinergics. What? Midriasis, dryness of mouth, then you can urinary retention, constipation, tachycardia, hyperthermia, and dry skin. I will directly come to the drug of choice, that is physostigmine. Now if you come to beta blockers, what is the complication or side effects? Bronchospasm. Why? What does beta blockers do? Can anyone? They simply cause bronchospasm. Very important side effect. Bronchospasm, bradycardia, conduction block, insomnia, nightmares, very important. Insomnia, nightmares, depression. They block symptoms of hypoglycemia. Right? They block the symptoms of hypoglycemia. Okay. Exercise intolerance is also complication of beta blockers. Exercise intolerance. Now what is the drug of choice? Glucagon is the drug of choice for beta blocker poisoning. Okay, so they block the symptoms of hypoglycemia. Okay, that's it. Now coming to alpha blocker poisoning. Alpha blocker side effects or complications: postural hypotension, ejaculation abnormality. But the most important side effect is floppy iris. Remember this. Floppy iris is the most important side effect of alpha blocker. Okay, alpha blocker side effect is floppy iris. Okay, now we finish most of the things are completed. I think, shall we discuss about cardioselective beta blockers, or we will get it for the next class, right? Shall we complete? Okay, then we'll discuss the cardioselective beta blockers. We have some MCQs. In this cardioselective beta blockers. What are the cardioselective beta blockers? I will just give you one mnemonic. Mr. Bean, cardiologist. M for metoprolol, B for bitoxolol, bisoprolol. M for metoprolol, B for bitoxolol, bisoprolol, E for esmolol, A for etinolol, N for nebivolol. And this is the most cardioselective beta blocker. This is an MCQ. Nebivolol is the most cardioselective beta blocker. A for etinolol and acebutolol also. Okay, and C for carvedilol. C for celiprolol. C for celiprolol. And nebivolol is most cardioselective. That's the main points here. Now sometimes you may get a question, what are the third generation beta blockers, if someone asks you. That is bitoxolol, nebivolol and celiprolol. It's the mnemonic. Bitoxolol, nebivolol and celiprolol. These are the third generation beta blockers. Now if someone asks you beta plus alpha blocking properties, labetalol and carvedilol. If beta blockers with nitric oxide releasing property, it's nebivolol. As we also discussed, nebivolol is the most cardioselective. It has also nitric oxide releasing property. Now Beta blocker plus antioxidant function, carvedilol and nebivolol, carvedilol and nebivolol. Carvedilol and nebivolol, right? Okay. Now we will discuss something. It is important. You may get a graph in the exam. Effects of catecholamines on heart rate. Okay. Now I will just draw a graph here. Just simply watch this graph. Now if you ask me, isoprenaline, which is one of the most important catecholamine, it has a positive effect. Isoprenaline, it is maximum increase in heart rate. It shows the maximum increase in heart rate. Now if you ask me epinephrine, it increases the heart rate but not more than isoprenaline. It increases the heart rate but not more than isoprenaline. Now dobutamine, it just maintains the heart rate. It neither increases nor decreases. It just maintains the heart rate. That's it. It neither increases nor decreases. This is dobutamine. It just maintains the heart rate. Remember these statements, guys. You may get a question on this. Now if you take norepinephrine, what does it do? It decreases the heart rate. See in this, norepinephrine increases heart rate in a transplanted heart or a patient who is on atropine, while ivabradine, it just makes a normal contraction of the heart, plus it also decreases the heart rate. Okay, so that's the thing. Now we will discuss some points about dopamine, because most of the times you get questions on dopamine. I will discuss something about dopamine. It's given as continuous IV infusion. I think you will seen in your hospital wards or your hospital setup, you seen dopamine is given as a continuous IV infusion. It's not some other thing. It's given as continuous IV infusion, and it is a dose dependent. It exhibits dose dependent action. It's microgram per kg per minute. It exhibits dose dependent action. So for example, if it is 0 to 2 microgram per kg per minute, then it gives renal vasodilation. It causes diuresis. Or it is from 2 to 10 microgram. It causes increase in cardiac contraction. If it is more than 10 microgram, it causes vasoconstriction. And the use of dopamine is similar to epinephrine. Now if you talk about epinephrine drug, you might get a doubt like, why SAR is discussing exclusively some drugs, all the doses, all their actions? Because most of the times you will get a clinical scenario. It's not a direct MCQ. You will get a clinical scenario. For example, 24-year male met with an accident, come with a severe hemorrhage, second degree hemorrhage. So so your senior professor has instructed you to give epinephrine. Now what sort of dilution will you do to give it to the patient. So you will get different options: 1 is to 1000, 1 is to 10,000, 1 is to 1 lakh, 1 is to 10 lakhs. So what is the answer? 1 is to 1 lakh, subcutaneous or intramuscular or endotracheal. Endotracheal, it's 1 is to 1000. But if your professor, if the examiner asks you the intravenous infusion of epinephrine, then what is the dose? It's 1 is to 10,000. 1 is to 10,000 if it is IV, intraosseous or intracardiac. So if it is subcutaneous, intramuscular or endotracheal, what is the dilution that you should give? It is 1 is to 1000. It is 1 is to 1000 dilution. If it is IV, intraosseous or intracardiac, what is the dilution that you should give? 1 is to 10,000. You got it? For local vasoconstriction, you should give 1 is to 1 lakh. These dilutions are very, very important. Okay, epinephrine along with local anesthetic, if it is given, that is, for example, lignocaine is a famous local anesthetic. What is the dilution? Can anyone? 1 is to 1 lakh or 1 is to 2 lakh if epinephrine is given with local anesthetic. You got it? Okay, rest of the things we'll discuss in the next class. I think it will be sufficient up to this point. We'll just stop it here. Next class we'll discuss all other topics. Till then, bye. Just revise all these topics. You just go through your notes. Till then, bye bye, your wise doctor. Have a smile. Thank you.